Welcome to this forum. This is the Let's Talk COVID-19 series. We are, which has been organized by the Kenya Registered Nurse Anesthetists Chapter. We are a chapter registered under the National Nurses Association of Kenya, which is a professional body that brings all the nurses and midwives that work within the boundaries of our country, Kenya. And the focus of NNAK is to promote excellence in nursing and midwifery. So as a chapter, we are the agency that brings together the nurse anesthetists who work in Kenya. And our three primary activities are to promote continuous education, advocacy, and research on behalf of the nurse anesthetists. And this forum is one that is meant to further that one activity of promoting education. So those are the hosts for this meeting. So I'll ask my colleague Francis to move to the next slide.
Okay.
So this first episode, if we'll call it that, will focus on infection prevention and control and airway management, and it will be perspectives from two of our nurse anesthetists. The first one is Francis Jenga. He is a tutor at Kijabe College of Health Sciences, which is the training arm of Kijabe Hospital. So I'll ask Francis to wave to the people. And then the second panelist is Stephen Mugambi. He is a tutor for the newest KRNA training program that is based in Kisii, that is offered through the Kenya Medical College. I'll also ask Steve to wave to the people. So they will be taking us through these slides. And so I hope we will find this forum very useful. I'll ask us again to use the Q&A chat box that's on the taskbar of the Zoom platform to send any questions you might have during the meeting. We shall try and answer them during this forum if time allows, but if not, we shall find ways to send the questions that you've asked, collate them into a document and email them through the emails you provided at registration. So I'll hand it over to my panelists, Francis and Steve, to take it from here. So Steve, the floor is yours.
Thank you, Gatwiri, for introducing us. And I'd like to welcome everyone again into this series of talks with the KRNA and probably any other cadre that is within. And I'm happy this evening to talk to you guys and privileged for the opportunity to talk about the infection prevention and control and airway management, especially in our anesthesia practice during this time of COVID-19, because it's a new thing. We've had several other viruses before the COVID-19, but then they've not hit so hard like this one because it spread quite fast. So we'll proceed. Francis, I'll request that you move to the next slide.
Okay, a minute, sorry.
Thank you. So this is our roadmap that what we'll be using to talk today. We intending to cover mostly infection and prevention around the anesthesia, which means our practice, and contamination around the area where we practice. So to start with, we'll introduce the topic, and that's what I've already done. But then we'll do a preview of probably what COVID-19 is, of which I know most of us know about it. And then we'll talk about the infection control for the anesthesia or the anesthesia care providers and the area that we work on. infection control during patient transport, which are the patients that probably are confirmed with the COVID-19, and then protection of the anesthesia equipment that we use, because we realize we work with the airway, which is an aerosol generating procedure. And then how do we protect ourselves and the equipment that we use so that we don't be the carrying agents of the virus. And then also we see about the pre-operative evaluation, how we can change it so that it can suit this time. And then the management of anesthesia. And then we'll summarize the whole talk and then talk about maybe questions or the concerns that we have from wherever we are. And then we can be able to respond to those ones as they come. So still on introduction. So I know every one of us have read, especially being healthcare workers, we've read about COVID-19 and most of the information we do have it. So COVID-19 is it's the disease itself, but the causative virus is the SARS-CoV-2, which is the virus that causes the COVID-19 illness itself. And then it spreads through the droplets or air droplets, which means if somebody coughs or somebody sneezes, those droplets that come off, then we end up having, they carry the viruses themselves, and if you get in contact with them and probably touch your mucous membrane or get into your mouth, maybe touch the nose or something like that, or get into the conjunctiva through the eyes or the cornea, then you get the infection itself, or you inhale those droplets, then you end up contracting the illness. And then the incubation period, which is by the time you show up symptoms, it varies between 3 to 7 days, depending on your immunity. And then the range of the averagely somebody gets the illness and then up to around 10 or 14 days. But of late, mostly we've heard that after 10 days, most of the time, whoever who has the illness, if your immunity is good or you've been treated by that time, probably it wouldn't be infectious by that time. So somebody is healed after 10 to 14 days. So the problem with the illness is how it spreads. It goes so fast. And then 80% of the COVID-19 persons who are infected are asymptomatic, which is a big worry. And then only like 2% require critical management, whom we get to see that they down with the illness, the ones that we admit in the hospital and probably need a supportive care, who have pneumonia or acute respiratory distress syndrome. Those are quite a small percentage of these people who get infected, but the bigger population are in the community and we interact with them. That's now the big worry about it. So who is at risk? So everyone is at risk, but we have other people who are at greater risk because of one reason or another, and mainly because either they work in an environment that it's an aerosol generating procedures, or in contact to many people, or such like issues. But then in general, all of us are at risk. So including the pregnant women, the children, all those. But now coming to the healthcare workers, we are at a greater risk because we interact with patients. And once somebody becomes ill, before they know whatever that is ailing them, they come to us. And once we interact with them, we never know. Now that we've said that it takes up to 3 to 7 days, probably they have, but they've not shown the symptoms, and probably just having problems here and there. And then probably they've not spiked fevers, for example, but already they having sore throat. So by the time you take the history, if you didn't protect yourself, and or for example, if the patient didn't have a mask, then you may end up contracting the illness. And the other problem is among the healthcare workers, there are those who are working with those situations where either you dealing with secretions from the airway or dealing with the airway, of which are the the people who are working in the critical care, the people who are working in endoscopy, the people who are working in theater, which is anesthetists, because we intubate patients, and you never know. And there are many other reasons because of that. But people who are in close contact with the airway are more at greater risk as healthcare workers, of which, if you looked at the trends, nurse or the anesthetists are in the critical care. We go to the ICU. The anesthetist goes to casualty. The anesthetist gets into theater and all those, and we go also to endoscopy. So that's why we think it is a prudent, or it's a very, very key topic for us to be very vigilant and talk about. Next slide, please. So we have already highlighted about how many people, or the 80% that are asymptomatic. And then the other thing is the surgeries that we deal with are still many. So despite the fact that since the first time that we recorded our first COVID-19 case in our country, there was a lot of phobia. People really heeded and followed the protocols that were laid down. But over time, I think we forget too faster. And nowadays, you can even walk in the open places and find people without masks, and yet the number of patients or people who are being confirmed having COVID-19 is escalating, which is so much worrying. So meaning even the patients that we're tackling in surgery, patients who are being involved in RTA, for example, in the roads, they come back to the same theaters. So which means if that person is infected and now they've gotten an RTA, they're coming for our care, which is an emergency. And in emergency situations, you know, there are those situations where you see people losing lives, and then like, because you have that heart of caring, you pour yourself so much into that situation, and probably you may forget to protect yourself. But at the moment, because of the situation, so emphasis are, even during times of emergencies, protect yourself. The same thing like for the firefighters, like you have to read the bystanders. The bystanders now are that the COVID-19 that we're having. Be safe first as the rescuer before you rescue another person. So don't get carried so fast. Always look for PPEs or the equipment that need to protect yourself depending on the institutions that you are, so that you can be safe. And then the other question is there capacity to test all surgical patients for COVID-19 before every case? That is a big question that we have to ask ourselves. And I don't know where you practice, but in the institution where I work, sometimes, especially those cases that we're talking about, the emergency cases, let's even, for example, from the maternity, these are mother who's come, maybe in second stage arrest, they're rushing the mother into the theater. So sometimes you may meet even the patient at the door. You don't have that much time. So did they get tested for COVID-19? Probably not. And even in the main institution, sometimes most of the time the maternity patients come without being tested, which is a big worry. And the question is, are these patients at potentially having the COVID-19? The same question is yes, because now we're seeing whatever that is happening in the outside, in the trends of the COVID-19 infection rate that we're seeing. How do we deal with emergencies? A big question. The cesarean section, the RTA cases. So is there a way in every institution that we work in, like, are we having protocols, or are we having any other ways to help us so that we don't, like the same thing that we have the WHO checklist? It's the same thing. Never tackle a patient if you don't have the face mask. And nowadays, especially with the situation that we're having around an N95 or a K95. So let's move on with the next slide, please, Francis. So that's the situation that we are working into in at the moment, which is so worrying. So in this slide, it's just to summarize, there are many other procedures. So as anesthetists, we are risky because all these procedures, if you look at them, we end up participating in these procedures, be it laparoscopy, intubation, gastroscopy, head and neck procedures. When they are doing surgeries, maybe it's neuro, they're drilling, or maybe it's orthopedic procedures, they're drilling all those droplets that are being generated from the patient, tracheal extubation. Sometimes even the ICU, they call like, we extubating a patient, we just need your presence to be here in case the patient is not able to tolerate to breathe on themselves, so that you can still intubate this patient. Bagging the patients, especially when putting the patients in the, we want to put the patient to sleep. All these procedures are very, very much touching on us as anesthetists, and which means that the risk increases with the same job that we are working on. I mean, there are so many other procedures, in even putting the patients on oxygen via nasal cannula itself, especially if you put high flows that they're blowing out the secretions or the breaths of the patient from the airway and blowing them into the room. So that's also another risk, because where do we sit as anesthetists? It's at the head of the patient as we talk with the patient. So that close proximity, we can get into trouble with the same. So yeah, so infection prevention in the operating theater. So that's our main focus here. So what are our goals? Our goals are prevention of transmission to care providers, which are us. As to start with, the care providers, whoever who is handling the patient, and then also you mind about this next colleague who also will be handling these patients. The other thing is prevention of contamination to the anesthesia machine and other equipments that are around, including the OR table and the table that we're using, which is the anesthesia machine where we put our drugs and where we pick our syringes from, those drawers, all those places, the suction equipments. So these are the equipments that we are talking about in this situation. So prevention of transmission to care providers. So there are many measures that we've known about, we've been talking about, including using sanitizers, meticulous hand washing with soap, and the minimum being 20 seconds, or you can go up to 1 minute. And then all suspected or confirmed cases should be treated as per the protocols that are laid by the WHO or modified by your institution using the WHO protocols. And then use of PPEs is mandatory. We don't have an option in this situation at the moment. And if you looked at the Kenya Society of Anesthesiology recommendations about the COVID-19, they really emphasize that all institutions should be able to provide PPEs. So it's not an option. If there are no PPEs, then it's better that we don't handle these patients, which we see now. It's something that is very relevant, that we've seen even care providers that have lost lives, which is really a pain. And we don't want to see more of that. So meticulous hand washing and hand hygiene. Sorry, we've lost the screen. I don't know what has happened from Francis' side, but I have them on my phone. So, so meticulous hand washing, use of sanitizers, and use of PPEs, it's something that we cannot overlook. So it's coming up, which is still okay. So those are things that we really need to take care of so that we can be able to take care of ourselves. So the PPEs that we use, we're talking about, the next slide, please. We're talking about the use of face shield, as we can see in those pictures. The use of a face shield, the use of a mask. So I have several type of masks. So the recommended masks are the K95 or the real N95. And the N95s, we have the FFP2 and the FFP1. So note of that, and then we can talk about that one. We have the K95. This is not any different, but all of these masks are working the same thing like N95. They protect 95% of the aerosol, what we breathe in and what we breathe out. 95%, that's the name K95 or N95. That's how they got their names. And then we also have the surgical masks. So the surgical masks are less protective as opposed to the N95, whether it is a K or the N95. So the K95 is a China product, that is approved by the China nationality. And then we have this is a US standard, which is the one that is also recommended. So there are slight differences between the two, but the protection is the same if they are applied the way they are supposed to be used. And then also you can use a complete face shield, or you can use the face shield, the eye shield that we have, the normal glasses that can be able to cover your eyes, to the like the ones they use in operations. And then hand sanitizers, you can be able to see a hand sanitizer that is hooked up to the stethoscope, so you can hang it anywhere else. And then the gowns, and then also the gloves, which we need to double glove, so that if you're doing a procedure, you only remove the top glove, and then once it's contaminated, and then you put another one, so because the inner one is protecting you and the other one is protecting that you don't contaminate yourself with the secretions or the virus from the patient. For example, if the patient is having a virus, the gown that is recommended is a waterproof gown. But depending on the institutions, if the patients are not known, if the patients have come, they don't have symptoms, but then you don't know their status, it's good to get even the gowns that we use for surgery, that depending on the institution, some of them are waterproof and some of them are not. But ideally, if you have a waterproof, they're better. So next slide. So this slide is just talking about on how to protect ourselves. And then the head cap, you realize on the slide, the anesthetist is using a clothed head cap. Ideally, we should use the disposable ones, because once we're done with the patient, then you can remove that disposable one and throw it away. Unlike the clothed one that you can carry it back or to your locker or back home if you're using a bag, so that to minimize the infection being carried from one area to another. But if you're dealing with a COVID patient, everything is disposable. This is just for those patients, probably we don't know their status and they don't have symptoms, or we don't suspect that they have symptoms. Because nowadays it's become like every other patient that we're dealing with, we need to get protection of gowns on top of our scrub. The scrubs we're using the scrubs for the entire day. Next slide, please. And then on this is about protection of the equipments. So you realize from this anesthesia machine, there is a HME filter. And then in this situation, we need to use HME filters. So in adults, the HME filters, you can use, ideally we need to use 2 of them. One on the expiratory limb, and then one just before the before the endotracheal tube or at the elbow, so that it protects any. And then once we're done with the patient, then the entire circuit is removed and the HMEs are disposed, are discarded, so that the plus the circuit itself, and then we use a new one, especially during this time of COVID time. The other thing is the CO2 sampling line. It's something we normally used to reuse, but at this particular point, if it has to be reused, then it has to be cleaned with antiseptic solutions really well before we get to use it with to another patient, which means one patient at a time, and then everything else has to be dismantled. The HMEs have to be disposed, new ones placed with the new circuits, and then with a new sample line that has been cleaned with the antiseptics. On this other, the picture on the extreme right is a suction tubing with a anchor. Normally when they are bought, they're in that polythene. So we did put this slide or this picture on the slide because we realize when we're using suction, or when we're suctioning the airway of the patient, what normally we do, we tuck in the anchor below the mattress of the patient without the sleeves. So which, on thinking, it's those secretions that are at the tip of that anchor, some of them remain by that below that mattress and on the surface of the OR table, which is right at the head where we normally operate from. So which means that we're contaminating that area. And once the patient is out, probably whoever who is cleaning, which means the cleaner, will not protecting them. And if by the time we're coming back to for another patient, we assume that that bed has already been cleaned, sometimes you might find yourself touching that surface even without gloves, but which is really wrong. And this time, so this polythene, we can retain it, just make a hole, remove the entire suction tubing and the anchor, but retain that polythene so that once you suction the airway, you put it back into the polythene carefully so that it does not touch from the outside, and that becomes the sleeve of that suction. In that way, we're preventing those contaminating the area that we were working on. Just an improvisation. But if you have any other material that you can use, equally well, but it should be something that does not seep through by the secretions cannot seep through. So something that is waterproof. Thank you. We can move to the next slide. So any questions so far before we proceed? Okay. So still on the, about the infection prevention. So still on infection prevention of the equipment. So only necessary equipment should be kept in the OR during an aerosol generating procedure, especially during general anesthesia cases, so that we don't put things that we don't need and probably contaminate them. And maybe there are those drugs, or maybe the resuscitation drugs that we use. For example, if adrenaline, you have diluted your adrenaline, ephedrine, or even phenylephrine, or whichever drug that you've diluted for resuscitation of the patient in case during the case that which normally we do. So all these things, we should just minimize whatever that is on top of that table so that we don't contaminate the area that, or the working table that we are using. Sorry, Francis, you went a little bit ahead, but it's okay. So on still on the things that we wear, the PPEs that we wear. So wear masks at all times during transit. Sorry, yeah, just maintain there, Francis. Thank you. So especially when transporting those patients that are suspected or confirmed. So on how to prevent infection from being or contaminating wherever we're walking through. So make sure that we protect ourselves by wearing masks, and also the patient has to have a mask applied well so that they don't have like areas that can be able to leak around. And sometimes to improvise, you realize when you're putting a mask, if somebody does not bend the wire that is normally on top of the mask so that it just applies neatly on top of your nose, sometimes you have those gaps in between. So sometimes what you can do is just get the normal tape that we use and then tape halfway of the mask and half of the tape to get through the nose of the patient and your nostril and your nose as well, so that you minimize the gaps in between, especially from on top. Probably whatever that will remain will be from the side, because if they cough, probably something cannot come out this way, but it can go sideways. And then the other thing is, ideally they should be transported using the OR bypass or holding area, which is designated that the area which is not normally used by most of the staff, or an area that is cleared for the patient just to get to either the OR or to the holding area where they need to get into. And then the other thing is high quality HMEs, the viral filters, should be inserted between the ambu bag and the patient at all times if they are intubated, which is very key. And then clinicians should not touch the environmental services, which means wherever the corridors that we are walking through, there are those rails that are by the sides. So you minimize as much as possible, unless you're falling, so that you don't touch those rails, the elevator buttons, and the door handles. So if you get to the door, ask somebody from the inside, because now it's something you had already communicated early. to be open from the inside rather than you who is having the patient to open from the outside. That way we minimizing contamination of the surfaces and also whatever other people may end up touching. The patient should recover from anesthesia in the OR and then transported directly to the isolation room. So whoever who is dealing with this patient, make sure that the procedure is done, they recover fully, and then they are transported directly from the inside the room to the isolation center, which is very key. Let's move to the next slide, please. Thank you. So we have talked about the equipments and the that we need to get to wherever we are working should only be those that we need at that point. If there are any other ones, more probably then the assistants can be able to hand them in to us. And then keep backup emergency equipment outside but near the OR, which is self-explanatory. And that's for infection prevention and contamination as well. Prevent service contamination. We can't overemphasize that one. We can keep reminding ourselves in wherever we're working to just minimize as much as possible from touching the patient, touching to the other surfaces, whether they're anesthesia machine, the knobs, setting up the machine. So if you have to put a patient on general anesthesia, then you preset your machine way earlier before the patient comes into the room. So one thing with the COVID patients is early setup and making sure that everybody is on board and they know their roles. So we normally do that, but this time around it has to be plainly clear and everybody's role has to be very, very clear. And whoever who has questions, they need to be cleared before the patient comes into the room. Use of 2 high quality filters. I think I had talked about that one, especially when we were at the machine, and then where to put them. That's very key. And then preventing contamination of multiple components of anesthesia machine is critical, as noted by the Anesthesia Patient Safety Foundation, which we have overemphasized. And I think because we are protecting ourselves and also the other users, because after you, another anesthetist is gonna take over probably for the night or even for the following day, or during the weekend, somebody else is coming. So if you did it quite well, and then once we are done, we can spray the alcohol using the small cans that we normally spray in the OR, decontaminate the area with the alcohol that normally we use in the OR to prep patients. And then that way we keep the environment quite safe. Next slide, please, Francis.
So maybe
Yes,
just before you proceed,
okay.
We've gotten a question from one of the participants about the masks, the K95, and
yes.
There are some concerns that is not recommended. So I know from the question, I'll read the question as it is. Please clarify on the K95 because there are concerns that they're not recommended, and KSA is currently working on this clarification.
Okay, thank you, Gertrude. So yes, the K95, from most literatures that I've gone through, the big difference is that this is China approved and the other N95 is US standard approved. So the K95, the difference between the K95 and the N95 that is approved by the US is that when you are put it on, it does not cover your mouth and nose completely or tightly as it should, so that it can protect the caregiver and the patient or whoever whom they are handling. So there are those chances that the aerosol droplets can get in contact with the provider. So that's the big debate about the K95. But on how its efficacy between it and the N95, if it's applied well, of which now well is quite debatable. And that's the big contention about it, and the questioning about its standards. But on literature so far, they say that its quality with the N95 from the US, it's not any difference, apart from that it's way that it covers or it's applied around the mouth and the nose. It's the big contention.
And then the next question would be with the anesthesia machine. There are two schools of thoughts. There are some who say you don't need to cover it as long as you clean it. That is sufficient. And there are others who recommend that you cover it with a plastic sheet.
Okay.
So what would your comments be on that?
Okay, nice question. That's a good question. Francis, do you want to respond to that, please, before?
Yes, of course, Steve, thanks.
Yes.
I think in an African setting, the best and cheapest and most affordable and effective method would be to clean what are called the high touch areas. Of course, from literature, they talk about covers because they have custom-made covers that are, that are cut out to fit the anesthesia machine, such that they have holes for the knobs, they have spaces for whatever, like the oxygen flash and the components that you use mostly. They don't have holes, they are cut out such that you can use easily. But the easiest I would recommend is cleaning in between cases.
Thank you, Francis. Yeah, that's so the other question is that you can ask yourself about the using of covering the anesthesia machine, especially those areas that are not normally touched most of the time. If you are expecting a patient who is COVID positive, which includes any other area inside the OR, including the anesthesia machine and any other machines that are inside the OR that probably cannot be moved outside the theater, then they need to be covered by something that is waterproof, mostly polythene bags, what I've seen being done in one of the institutions that I've visited. So including sockets where people touch, okay? And sockets for either charging or putting lights on or putting the machines on. They are covered with a polythene paper and then taped around so that by the end of that procedure, then they carbolize the room, they spray the room, and then thereafter they are removed. So even the anesthesia machine, those areas that we don't normally use, like the back of the machine, on top of the machine, because with you realize with the droplets, they go up and then drop down, so that you protect those areas. But once that procedure has already been finished, then those polythene papers are removed after the contamination and spraying, and then that room stays for 3 hours or so before it's ready for any other patient to get into that room. So covering of the machine, the other question is, how often do we change the covers that we put on top of the machine? I know when we were training to get organized and keep the anesthesia table clean, we used to put a cloth or something on top of that machine so that we can arrange the drugs on top of it, but we use not to change it like that often after every patient. So that's why Francis is saying, how often do we clean? It's best because those surfaces are cleanable and wipeable quite well without any problem, and then we can spray with every patient, which is easier than putting a cloth and then removing it again, unless those clothes or they are disposable or either they can go back and get cleaned again. So to prevent many other problems, unless you can be able to change it after every other patient, then it's best that you just leave it without any cover and then you clean it or wipe it after every patient. Okay, so I think we can proceed from there. So, the perioperative assessment should include COVID-19 screening and testing, checking for both exposure and symptoms. So on the history taking, so it's also something that you include in your history. Nowadays, initially we used to ask, is the patient coming from a region that is high risk areas? Initially we used to ask the patients, do you come from Nairobi? Do you come from Mombasa? Are you coming Now it's everywhere. I mean, you can't ask the patient where they're coming from. So the ideal thing is if they're coming for surgery and you're doing a pre-op, if they are elective, have they been tested? And when were they tested? What were the results? And then do they have any symptoms of COVID? Like, do they sneeze? Are they having a cough? Are they having a running nose? Any just issues with breathing? Any difficulty breathing? Are they having fevers? So on history taking, that's something that we can be able to evaluate from these patients. Risk of the surgery for COVID-19, patients should be determined. So if the patient, for example, has not been tested, or they're coming for a procedure and they have been tested and they are COVID, for example, and they schedule for a surgery, is it an emergency? Does the surgery need to be done? I mean, why then should we do the surgery? The patient can go, get treated, get well before we do the procedure. So those are the category of patients that we don't deal with until when they are negative. Unless it is an emergency, then we take the normal precautions, and then we can be able to we take care of those patients the way they should. High rates of post-operative pulmonary complications and mortality have been reported, especially with those patients who are positive. And once, if you realize most of these patients who are put on vent, their survival or recovery rate is really minimal, and most of them end up succumbing. So follow institutional protocols. That's very key. And it's good as an anesthetist so that we know what is acceptable internationally, what are the protocols that have been set by the World Health Organization, what are the protocols that have been set by our Ministry of Health, and what are the protocols that have been set by the Society of Anesthesia, and whatever the institution that we are working with, what has been customized to work with. If there isn't one, then we need to develop one, which is very, very important. We can move, Francis.
Steve, before we move, it actually got very controlling. Before we move, can I add something about the post-operative complications?
Yes, please.
So just to create a picture on how high the complications are. In one recent international studies, they were looking at over 1,000 COVID positive patients who are going for different surgeries. These were about 1,200 patients. And out of this, 51% actually had pulmonary complications.
Thank you for that input.
Yes, out of the ones who had pulmonary complications, a 30-day mortality affected about 36% of these people. So it's imperative that you have to decide whether you're going in for surgery or not.
Yep. Thank you, Francis. So this slide is something that we need to ponder about to reduce the risk of us getting or exposing other caregivers about the choice and techniques of anesthesia. So general versus regional anesthesia should be determined by the procedure being done and the patient status. So regional anesthesia not contraindicated. And actually, if you can effectively do a regional anesthesia and avoid doing a general anesthesia on these patients, the better. Because you realize you're not exposing yourself as much because you're not intubating this patient, as opposed to when you're doing a regional anesthesia. Unplanned conversion from regional anesthesia to general anesthesia should be avoided if possible. So if you go the regional anesthesia way, you should do all the efforts to make sure that that method works, because now if you have to change in between to go to general anesthesia, then probably you may end up risking yourself more as opposed to when you are ready to intubate this patient, because that way you are already you are ready and you are prepared, you are already with the PPEs, which means for you to contaminate yourself and risk yourself will be at a smaller risk as opposed to converting regional to general anesthesia. But then that tells us, just as normal as the way we normally prepare for regional anesthesia, we should always be ready for general anesthesia. So which means when we're doing this regional anesthesia, we should also have in mind that probably it may end up, or sometimes as they normally fail in this percentage of patients, we may end up landing into general anesthesia. And then patients should, who do not receive general anesthesia should wear their masks throughout the procedure. So what I've seen, sometimes managing patients is quite difficult. I mean, wearing masks and making sure that they wearing them the right way. It's not, it's something that is calm, and most people, others are very ignorant. They just think it's just applying the face mask on their face, and that's it. So they end up not putting it on top of their nose, but just covering the mouth, and sometimes it's just below the chin. You realize that one, and you tell the patient, put your mask, kindly put your mask in the ideal way. They put it in 1 or 2 minutes if they are probably under spinal anesthesia, and the next few minutes, because probably they didn't coil that metal on top of it, of their nose, it slips down and it remains there. So you keep reminding them from one time to another. That's why I brought up the idea of probably taping it to the nose. Because sometimes, I mean, it's just something that we have to be serious. COVID is real, and it's something that we can't overlook. If the patients cannot be able to take care of themselves, sometimes you've seen even in surgery, sometimes when they do operations, let's say a laparotomy, and the patient's NG has to stay inside, they switch it to the nose. I mean, just so that when the patient try to pull it out, they cannot, they feel that pain. So even for these patients, sometimes they do it unconsciously, but if we taped it up, then probably they try to remove and then they remember, oh yeah, I should not pull it out. And then if we're using supplemental oxygen is required during regional anesthesia, lowest floors to maintain oxygenation should be used. As long as the oxygen then is above 95, then we can accept that one. We should not use high flows, and also which will lead to blowing up of the pathogens from the nostrils into the surrounding air. In general anesthesia, use rapid sequence induction. So this is just, think it about, you want to use the least time possible around the airway, that's one. Then you want to get this patient to sleep as quick as possible and minimize your time of exposure around the airway. So which means whatever that we're doing should be that effective, organized, and that fast. Everything has to be where you want it to be, including the endotracheal tube. It's not that you're going to look it for it somewhere else, that you have to lose your focus on the airway and then go grab it from somewhere. Somebody is just there, your assistant or whoever who is circulating in the room, to give it to hand it to you, to your hand, and put it in, inflate, and come out. So that brings into the conversation. So the intubation. So if you're having, for example, a COVID-19 patient, so who should handle this patient? It's not somebody who's just come from school, or somebody who is experienced with handling the airway is not that competent. If you're having doubts for any reasons, probably it's good time that you look for the most experienced anesthetist or the anesthesiologist to handle that airway. And the other thing is, it's not time that you probably for the unanticipated difficult airways. Let's say you did your pre-op quite well, but you didn't anticipate. Sometimes you end up by the time you're doing your DL, and then trying to intubate, the airway is quite anterior, you can't get it, and then now you have to change tactics, look for a stylet, look for a bougie, and probably ask for a fiber optic. So these situations in this era, I'll suggest that all the equipment, and that's why preparation for anesthesia is very key. This is a time that as anesthetists, we really need to get organized, okay? Just from the word go, get all what you need where inside the room and within reach. Yes, we've said that all the unnecessary equipment that we are not using, we keep them somewhere, but that somewhere is where we can reach into. maybe in the anesthesia drawers, where once you just need to pull it and somebody feeds the stylet into your endotracheal tube and then you intubate, or just pull the bougie out from wherever it is, from a sleeve, and then shove it into the airway and then put the endotracheal tube. So that's the organization we're talking about. It's something that we need to embrace. I know we get organized, but during this time, we really need to be very organized. Basic principles of difficult airway management apply to the COVID-19 patients the same way, but now the organization has to be top-notch. Next slide, please. Yes, so this is one of the slides that I think are very key, and I will just highlight some of the areas, especially during the team dynamics and then the technical aspects about this, because we talked about the before, the hand hygiene, we've talked about those ones, staff protection, those things about the aerosol procedures, wearing of the PPEs, we've talked about the preparation of the equipment, and then the team dynamics. So in the team dynamics, on top of getting organized, is that every person in that room know their role very well. That whoever the team leader is already known. And then if you are the anesthetist, your duties are already known. Your assistant knows whatever that is required of them very well as well. The circulator, the same thing. Whoever is circulating inside the room, whoever is circulating outside the room. Also, all of these people are well coordinated, and every role is being distributed and is well known to everybody. The other thing is about the technical aspects, the airway management, the equipment, the practitioners, all of them, the equipments are inside the room, the practitioners are all ready and donned, and then tight fitting masks with 2-hand grip to minimize leaks. So this point here is that in the event of a COVID-19 patient, so whatever that we're doing, especially when we pre-oxygenating these patients, okay, this is the situation where we deal like these patients normally who are full stomach, where we normally do an RSI. We pre-oxygenate them way ahead, very well, those 3 minutes or 8 tidal capacity volumes. And then once that is done, if you need to bag this patient so that you minimize any blowing or increasing droplets into the room. So somebody, whoever who is holding the mask, the 2-hand technique is applied so that you don't have much of the air leaks around the mask, and then somebody else is bagging. But now when you are bagging this patient, you don't put too much pressure on the bag, just enough to have a chest rise and not to get leaks around the airway, so that you don't increase the droplets from the patient into the environment. And then the other thing is, as much as possible, avoid this patient from coughing. So which means your medications of induction, you have to give them adequately. So whatever that you give, if it is sodium thiopental, propofol, or ketamine, and paralyze the patient, all these medications, according to the weight, I will not use the lower mark, which is like 1 milligram to 2 milligrams of saxamethonium. It's not the time that you give the 1 milligram. I'd rather go to the 2 milligrams so that you maximize your chances and minimize the chances of this patient coughing up as much as possible, because that way you reduce the droplets from the patient into the environment. Thank you. We can move forward, and then if we have any question, we are almost done. So here, having talked all about the infection prevention to the care providers, for ourselves, and then to the next people who are around us, which are the staff most of the time, even including those cleaners. We mind everybody else. And then also from we to other patients. So in view of that, there are many, the WHO and many other organizations, the CDC, have come up with protocols, okay? We have the national protocols, and we have the country protocols. We also have the facility protocols. So all these guidelines, we really need to be aware of them. The first thing, we really need to know what is needed of every other protocol, what is the requirement and what is required of us as care providers, what is our role and what is the role of the institutions that we work for. And then that way, with the guidelines that we have developed in the institutions. So the other thing, it's not good enough to have those guidelines alone without being followed, which is now our big part as the care providers. We need to follow the guidelines. And if they are not there, then we need to develop. If we've not developed, we can use whatever that we have for the country and whatever that we have from the World Health Organization. And they are really good ones. So the take-home messages, protect yourself, which is very key. You can't rescue somebody if you yourself is at risk. We can't overemphasize that one. Always keep reminding ourselves, frequent hand hygiene, proper donning and doffing, and be vigilant. One thing that I'll talk about, during the Ebola time, most people who lost their lives as care providers, the only problem that got to them, how they got the infection, it was during doffing. So donning, not much of a problem because it's usually the low risk area because you're donning from an area that is not the infection is not in that area, but then you move to the patient and then you get to the doffing area. So those people who used not to follow those guidelines, removing of those PPEs the way they should be and decontaminating them the way they should be, using those procedures, and most of them are those ones who got the illness and succumbed. So especially during doffing, be very, very careful. Okay, being provided with the PPEs is one thing, using them properly is another thing, and then when getting rid of them and decontaminating them is a very key. Don't overlook such situations, especially on those patients that are coming that not been tested or proven positive, but we highly suspecting them. Some of them, I've seen them turn positive after the test. So ask yourself, if you are not that careful during that procedure, so you will have those worries around yourself. You're going back to your families, you're going back to other colleagues, maybe in the launch areas where you take your chai from, you interact with people, so you're risking other people. So always be very careful about those ones. Protect others. That's know the risks that we carry, and also the aerosol generating procedures. Be very careful with those equipments. Protect the equipments. We've talked about the anesthesia machines, the suction, the surfaces where we're transporting these patients, and then protect other patients from the infection, which means that once we handle a patient, we should not go to another patient without hand washing, changing these gloves and probably the gowns that we're using on, and then hand sanitizing where possible. But hand washing is number one with soap and water, running water. So next slide. I think we're done with the slides. This is our references that we got this information from. So you can take them and then go visit those sites. And this is the last slide, which is talking about stay vigilant. You see, the same thing. When you go into a park, probably visit hippo points or wherever hippos are kept, you only see a fraction of this hippo, but the big part of this animal is beneath the water. So this patient that we see is a small fraction, a small representative, but the big problem is within the community, those people that we don't know about. So vigilance is very key during this time. Everybody is a suspect, everybody is COVID-19 positive, unless proven otherwise. Thank you for listening to me. So Francis, if you have any input, and we can take any other questions, hopefully we have enough time.
I think we can take the questions. I'll just give my input as we answer the questions so that I don't sound like a broken record.
So
Okay.
we have a few questions that people have sent, and so I will ask the ones who are raising their hands to please let's use the question and answer forum to send our questions. It will be very difficult for us to allow everyone to speak during this event. So please, if you have any questions, please type them into the Q&A section on your toolbar. So I think we can give ourselves maybe at least 20 minutes. I know we've gone over time. We'd planned for 1 hour, but please allow us to go until at least 8:30, and then we can end there just to go over the questions that people will be typing. So I think one of the questions that has been asked is by Hilary Mahasi. He's asked, after 10 days, the disease is less infectious. I think that's what he meant. So what are the recommended PPEs when handling these patients?
So can I take that? So Hilary, I think it depends. If you're saying after 10 days the patient is less infectious, coming from a point where they were positive, I would rather use a negative test to decide their current state. However, if you are treating symptomatically and you think they are less infectious, I'll still use a full done PPE.
Okay, thank you for that. The next question is from Janet Malelu, who's asked, what do you use to disinfect the machine, and for how long should you wait before you connect to another patient? Hello.
Hello. Yes.
Yes.
So
I think Francis amehang kidogo. I think
oh,
Steve
okay.
can take that.
So what we use to decontaminate the machine, because most of the time what we have is the alcohol. So unless it's a COVID positive patients, there are those sprays that they use to decontaminate the whole OR area that they spray. But then what we have, the surgical spirit, we have these can sprayers that we normally use because it dries up quite easily. And sometimes we can have seen the enzymatic solutions. So sometimes, especially with the contaminated areas with the blood, because now you can't use jig on the machines because it corrodes. Enzymatic is it's better as opposed to the jig solutions or the chloride solutions that we use. And then the other thing that most sources say that is effective with it's the hydrogen peroxide. So either of those, you can use them. Now the time to wait before you use to the next patient, it depends with the solutions that you use. So if it's a COVID positive patient, normally those solutions that they use, I'm not quite sure whatever that they use to spray the room, but then the recommended time before any other patient gets to that room is after they spray, then it has to remain without any other person getting into that room for 3 hours minimum. It can stay even longer. And then after those 3 hours, it is now cleaned again by the institutional staff, because now those sprays, you have to clean them from the services again. They can either use whatever that is recommended with those institutions. And then from there, it can be left dry maybe for some 10 or 15 minutes or so, and then now you can put in another patient. But if you're using alcohol is, until when it evaporates, it takes like less than 5 or so minutes, especially for those patients that are not positive, just to take precautions, just to spray and wipe and then let it dry on itself, and then you can get another patient back in. But for the circuits or the other equipments like the laryngoscopes, you can soak them. Normally the way we used to soak them, the 10 minutes, and then clean them with running water, make sure that they get back for sterilization, especially the blades, and then get them back, and then you can use them to the next patient, depending on the institution that you have. If you don't have a sterilizer for the laryngoscopes, then enzymatic solution can be the ideal way to go. Suck it in an enzymatic solution for those 15 minutes to sterilize it, and then you can use it for the next patient.
I think the next question focuses on CPR for COVID positive patients. So if you get a catastrophe intra-op, what will be the best approach or maneuver to use if you have a COVID positive patient?
So,
yes, Francis,
sorry, Steve. I'm sorry about my internet. So it depends. If your patient is not intubated, what is recommended by the new guidelines is that you capitalize on apneic oxygenation until you can secure the airway. So you're doing CPR and you just attach some oxygen. And if you need to secure the airway as soon as possible, and the time you're securing the airway, then you back off chest compressions. That's the most recent recommendations.
So yes, it's very sorry for such situations. I know we used to, it's difficult to see a patient die and you can be able to do something and bring them back. But the current guidelines with the COVID-19 positive patients, CPR is not recommended, unfortunately. So if they stop at any point during the operation, then that's it. We don't resuscitate them.
So I think the American Heart Association had developed an alternative
maybe
protocol.
An automated something?
Yes, for CPR patients. So what we can do is, this is the kind of resource information we shall send to everyone who registered and attended this event. We shall send them through the email. So please, some of these questions, we might not be able to get to all of them right now, but we will be sending you all the resource materials you'll need to answer the questions you've been asking and expound on some of these things. So we'll share that information with you. So I'll move to the next question, which is about ETT size. Is it a factor to consider? Should you use a smaller size to reduce the risk of an airway edema?
So I don't know. These are tricky question, but my school of thought, every time since time immemorial, when it comes to ETT, you want to use the biggest ETT that has that will cause the least complications. It doesn't matter, because you want to have good ventilation. I don't know if this is isolated. There's a different case for COVID positive patients, but I'll use an ETT that I'm comfortable, that I'm able to achieve good ventilation, and of course not traumatizing the patient by causing edema and such.
That's very true, Francis. And the other thing you think about is a tube that does not leak, okay? Because you want to minimize as much as possible the leaks from the airway. So yes, you may be worried about edema around the airway, unless it's 3D matters that you may need to go through a smaller tube, but ideally use a big tube as much as possible, because of the same thing that Francis has talked about, because you need good ventilation. And also the smaller tubes, the higher the resistance. So you need something that can be able to get or to oxygenate or ventilate the patients with ease. And owing the fact that they have viral pneumonia and such like issues, those are patients that probably need just good ventilation. So smaller tubes would be a little bit of a challenge to ventilate them, on the other hand.
Question is, the next question is on the closed system machine in ventilation of a patient. So I'll combine two questions. Someone asked us to comment on that closed system, and also comment on the solder line in the anesthesia machine. if you suspect that there's a contamination in that closed circuit? Is it practical or scientific to discard the soda lime, or what are your comments on that?
Yeah, so there's no scientific, it's not been proved that you need to change soda lime over the CO2 absorbents, and they've of course checked that in numerous studies. Number one reason is based on the fact that you're using high quality viral filters, which is HMEs. And
Okay, sorry, I think Francis is having challenges with the internet. Yes, as he was saying, we don't have scientifically all the studies that have been done. The contamination of the soda lime is something that is not proven, and probably it's like they've not found the virus in the soda lime. Okay, so if we're using, and the other thing is we're using high quality viral filters. You realize in adults there are two. The other thing that I didn't mention about in pediatric, because of the resistance, they recommend using one, which is at the before the endotracheal tube, so that you just minimize the resistance, because now pediatric patients breathing through the HMEs or ventilating them through the HMEs is creating resistance as well. And most pediatric patients, we normally let them on, depending on the procedures, unless it's X-lapse or something, then we don't paralyze them. We normally leave them on spontaneous, which at this point during COVID time, it's something that you have really to think about. If that it's a big kid enough, you can still paralyze them, but also weighing the risks of losing your patient or putting your patient at greater risk of ventilation, depending on the machine that you're using, if it is able to ventilate a pediatric patient, or you remain ventilating this patient by hand. So contamination of the circuit itself, yes, we've talked about it. We don't reuse circuits for patients. I know in our government institutions, that's a big question. So the machines that were brought, we have these rubber corrugated tubes that we use from one patient to another, but then it's not safe as much as we're using it. So if we can be able to request our institutions to be able to give us more that we can be able to clean as we're using the other one, so that by the time we're done with this, that one can be taken to Sulu's room and then clean, and then we use a clean one. That will be of real help. But with the HMEs, we have no shortcuts. HMEs, it's a must at the moment, especially high quality viral filters. And that's only for, sorry, Katrina, and that's for those patients that probably don't have COVID-19, but if a patient is COVID positive, then we have no option. We just need to change them.
Okay. Thank you for that answer. The next question, although it's not very clear, was the person has just written nasal cannula and anesthesia machine. So I think just expounding a little bit on the use of nasal cannulas.
Yeah, as you said, the way you've read it through, I'm not so sure what is the question with that one and what to expound on. But on my guess, I think the nasal cannula is hooked from the machine to the patient. And again, so nasal cannulas are disposable. We never reuse them. And then the other thing is, normally, because the oxygen blows from the machine into the patient. So if the question is like the pathogens from the patient can get into the machine, I don't think it can, because of that flow which is coming from the machine to the patient. It's not possible that it get tracked into the nasal cannula into the machine unless there is no oxygen that is flowing to the patient. But yes,
and the other thing, sorry.
Yeah.
And the other thing, it's actually pretty comfortable for patients to have the nasal cannulas on and still have the mask, the surgical mask on in OR. So it can work. It works well.
Yeah.
So I'll ask all the last three questions together because I think we have about 9 minutes. We don't keep people. So the first is on the school of thought, where you select a specific OR room and use it for COVID patients just to minimize the chances of spread. What do you think about it? So that one I can ask maybe Steve to answer. And then Francis, you can take the last two. The first is on your comment on the use of a video laryngoscope and a glass box. And then please comment on the use of HME and scavenging on confirmed COVID patients. So I think we can start with Steve talking about the isolation, and then we'll finish with Francis.
So thank you for that question. So for better management for positive COVID patients, every institution should have a COVID OR that is specifically kept for these patients. It can be in use, but it's already identified that in case we have a COVID patient, that's the room that it is signed, or will need to be prepared for these patients to go there. One of the things that they look into is this room accessible? Like, is it a room that can be accessible from somewhere where they don't have to go through the corridors of the entire theater? That's one. And then that this patient can be able to exit from this OR without going through the same main theater into the isolation unit. So it's the ideal way that we need to identify an OR that is designated for COVID patients, because these patients probably may need an urgent care into this intraoperatively. And so you can't say that we can never have such patients in whatever institutions. So if your institution has only one OR, that becomes a big of a challenge. But if you have more than one, yes, that's the ideal way to do it. Get a designated OR that is known and isolated, or kept somewhere that is known, that in case we have a case, that's where we go into and get prepared, and it's got a place where you can don and doff from.
Thank you for that. Francis?
Sorry, what was my question again?
The first one is a comment on
video laryngoscopy.
Video laryngoscopy, yeah. Yes.
Yes, so yeah, actually that's one of the recommendations, that if you can use a video guided laryngoscopy, because so that you're far away from the airway, is the best. About the glass, so COVID, we have new information about COVID every day, but one thing that we have seen is that there's a lot of innovation, and people are coming with different, different devices just to stay safe. So I can use a glass box. Some people are using some plastic hoods. So that's all based on the improvisation, just to try and stay safe from the virus and contamination from these mucus secretions and aerosols. So it is absolutely okay to use a glide scope and whatever kind of improvised device you can between you and the patient.
The last question was on the HME.
Okay, I don't know what about
HME and scavenging on a confirmed COVID patient, including a CO2 absorber.
Yeah, I think we tackled that. We said there was no evidence that you need to change the solder line, especially if you have used a HME. Most HMEs, especially if they're good quality, they will even have directions on what kind of tidal volume to use, when not to use them. Because again, if you use a big HME on a smaller patient like a pediatric, then you increase dead space, they'll be more resistant, they'll not be able to breathe. But they're like a small menu on the HMEs. So it's important to use the HMEs, and not just HMEs that have viral filters. And that way you may not need to change. If you use one right on the EGT and the other one at the end of the expiratory limb, then you're safe. The SACO system is safe. The other question that I think you had asked is about if you think you have contaminated the machine, and Steve had talked about this. You want to protect the anesthesia machine from contaminating the internal components. However, if this happens, you may need to contact the manufacturer or the people who service the machine, so that they can, they're the best people who know how to cleanse the internal components of the anesthetic machine. It's not something that you can do in theater.
So thank you very much. It's now 27 minutes past 8, and I think it's a good time to end this. I see my chairman, Mr. Sampson, has raised his hand. Maybe he will close for us this meeting. But I thank everyone who was able to join us for this talk. Please feel free to continue sending us questions, comments you might have on this presentation. We hope to be doing it every Friday at the same time. And we are also open to having other people from other countries share with us. And since we might not know everybody, please feel free to reach out to us. I will type my email address on the chat function. It's info@krna.org. You can send us emails on any questions or any topics that you might be interested in hearing from in the future. So let's keep, as the speaker said, keep vigilant, make sure that we protect not only ourselves, but the patients that we serve and the communities that we serve. So I'll hand over the meeting to our chairman, Mr. Sampson, to close this meeting for us, and thank you for joining us.
Thank you, actually. Thank you very much. Can you hear me?
Yes.
Yes, my name is Samson Mereti. I'm the chairman of Kenya Registered Anesthetists in the country, and I'm happy to see you guys. Thank you, Steve. Thank you with your team, Katweli. This is beautiful. We love it. This is the most great information we had for the last 4 months. We had this epidemic. Members, as Katweli said, we shall be having several series of these topics. It's my time to encourage all our members to participate, but Katweli and your team kindly make sure members can share their email so that we can look at this information closely. This is the most information we have in recent times. It's my hope and my prayer we shall all stay safe. We have lost one anesthetist in the country, and doctor, and several other nurses. And it is our prayer we shall follow the instruction, we shall be prepared by our team so that we can still continue being safe. We are doing great work in the country. Soldiers, let's continue and we shall overcome. Thank you very much, my colleagues, and have good evening. Thank you. See you on Friday, same time.
Thank you, Chair. And as I said, for the Kenyans, CPD points will be sent on email. The CPD code will be sent to your email if you attended the full event. Thank you.
Thank you.